Hi, Dr. Durgatosh.
Hi, sir. Shubham here, sir. Hi, Dr. Vivek. Hi, Dr. Pandey, sir. How are you, sir?
I don't think
Hi.
any. Hi, Dr. Geeta. Hello, ma'am.
Hi, Vivek. Hi,
Sir,
Durga.
sir, can you hear us? Acha, sir can hear us. Okay, okay.
Yeah, I can hear everybody.
Great, sir. Great. How are you, sir?
Geeta ko pranam.
हाँ प्रणाम क्या हाल है दुर्गा?
सब ठीक, all well, madam.
तो चमक रहे हो एकदम है? मैं चमक रहे हो प्रोफेसोरियल लग रहे हो प्रोफेसोरियल.
Hello.
हेलो.
हाँ. I can't.
सुनाई दे रहे.
Yeah. Is it okay?
It's okay, sir. It's okay.
So you've got participants in, huh?
Yeah. We have.
Okay.
So, sir, this is. You will be able to share your screen, sir. I've made you a co-host, so you will be able to share your screen. The format that we have is we do a small quiz, which Dr. Vivek has arranged for us, and we give the answers at the end of your talk. And usually, questions इतने difficult नहीं होते. आज Dr. Vivek ने अच्छे surgical questions डाले हैं. So, but the point is that it is just to stimulate everybody that they know what we are going to look into, and there is a little excitement there at the end of the class ki hamara kitna people have the right answer. So we'll start. It's 8:30. I'll start.
Incidentally, we're all have got a MAMC connection, huh, Durga?
Yeah.
You, me, and Vivek are MS from MAMC, and Shubham is MBBS from MAMC and MS from Harding. तो हमारा रिवर्स है थोड़ा सा.
I've done my MBBS as well from MAMC, ma'am.
हाँ, तुम through and through है, and Durga is also through and through MAMC.
आपका और शुभम का उल्टा है.
हमारा उल्टा है.
हमने तो सर का डॉक्टर दुर्गा का नाम डॉक्टर शारदा से बहुत सुना है, मैम. Throughout our MS, we have heard his name. So he was the kind of the ideal, मतलब guy to be looked up to, kind of. So we heard that name so often.
So Durga is, Durga will always be heard. He's that kind of person, so because he is a very academically sound person, but other than that, I think, he's short of a genius. You have to know Durga closely to understand that he is actually a person with a brilliant mind.
Okay, so it's 8:30. So
it's 8:30.
It's 8:30. Yes. Okay. So formal introductions. Good evening. It's 8:31 actually today, and today we are moving on to surgical oncology, and this is I think the 16th lecture of the Cancer Academy, and we are making it a good habit to meet every Wednesday at 8:30 p.m. with a new faculty of national fame who helps us, guides us, teaches us, takes us through a topic which is of common interest to oncologists. I don't want to put surgical medical radiation because we have divisions enough, but a oncologist, because that is how we see a patient in toto. And today we are going to surgical gastroenterology and liver cancers, where we have with us Dr. Vivek Mangla, who's the Associate Director of GI and HPB Oncology at Max Hospital, Patparganj and Vaishali, who will be moderating the quiz and the talk for us. And for the introduction of the speaker, those who did not already hear what Dr. Geeta said, I will give Dr. Geeta another chance to please reiterate what she said about Dr. Pandey. But let me just first have the quiz with Dr. Vivek Mangla. Dr. Vivek, I'll be sharing the screen, and then you can actually read out the questions. You will be able to do it much better than I would. That is why the onus is on you to read that. Just a second. So, okay. Okay, Dr. Vivek. So let me just get you the format of the quiz. So we expect the answers to be sent on this WhatsApp number 9953621242. I'll request Dr. Geeta to put this on the chat box number 9953621242. And we expect the answers to come as a single message. You write your name, the name of your institute, and then answer in a single numerical 1, 2, 3, 4, 1, which is the right sequence of the next 5 MCQs that Dr. Vivek is going to ask. Please don't send us 5 different messages every time we get a person who sends us 5 different messages. So just send us one consolidated message when the questions finish. And Dr. Vivek, I'll just put on the first question for you to read. Yes, Dr. Vivek.
Considering the fact that we were talking about surgical basis of liver resections, and I believe the type of liver resections would be considered. So the first question essentially is, which of the following is incorrect regarding hepatic venous drainage? The options being the middle and left hepatic veins usually unite together before joining the IVC. The RHV, that is the right hepatic vein, is usually larger than the left or the middle hepatic vein. Caudate veins drain directly into the inferior vena cava, and intrahepatic venous tributaries are surrounded by a fibrous sheet, just like portal triads. That's the first question. The second question is, which of the following is correct regarding functional liver anatomy? The right and the left liver functionally are separated by middle hepatic vein. The right anterior and posterior segments of liver are separated by the right inferior hepatic vein. The right and left liver are separated by the falciform ligament. And left liver is divided into segment 4 and the left lateral section, or the segment 2 and 3, by the left hepatic vein. The next question, please. So we have just put out a CT images. These images are actually of a recent patient who's had a Whipple for a periamputary cancer, but I just put up 2 sections at various levels. So the aim is for the quiz people to answer what is the segment of which liver segment essentially denotes the alphabetical letter A. I don't know if Shubham, can you just mark it out on your screen?
Yeah, if they can see the arrow here.
So the A is what segment they have to say.
This one.
Yeah. The next question.
So the options are segment 3, segment 2, segment 4B.
Segment 4B and segment 4A. So this is a recent specimen of our patient who's had a resection for a hepatocellular cancer, and we just want you to say what type of liver resection would result in a specimen which is shown in the figure. Would it be a right hepatectomy, or a left hepatectomy, or a left lateral segmentectomy, or would it be a non-anatomic or a monosegmentectomy? So the attached pictures are essentially of a patient with hilar cholangiocarcinoma, bismuth correlate type 3A, involving, I think it will be good if they read the CT images and go through all the 4 images. And what is the likely surgery which could have been done in this case is the question. The first option being left hepatectomy, the second being extended left hepatectomy with caudate resection with CVD excision, the third being extended left hepatectomy with caudate resection, and the fourth would be just an extended left hepatectomy. So if you just see the images, the kind of intraoperative remnant photograph and the specimen, by and large, people should be able to identify what is what.
So considering the nature of the questions, let me put question 5 as the distinction question, and whoever answers that will get the special prize. Otherwise, we will accept 4 out of 5.
I think even if they just see bismuth correlate 3A and the CT images, they should be able to say what would be the surgical procedure.
Yes. So I allowed this slide to linger on a little bit more so that you can make out the CT scan. And I'll just go back to the previous slide as well if you want to look at the scan again. Okay. And just to end the quiz, we expect the responses to come on this number 9953621242. This Dr. Geeta must have put this in the chat box also. Write your name, your institute name, and the answer, whichever is the right sequence, 1, 2, 3, 4, 1, 4, 3, 2, 1, whichever is the right sequence, and then send us in the next 5-7 minutes. Okay, thank you. So this has stopped sharing. And now may I request Dr. Geeta to please reintroduce Dr. Durgatosh, please.
I'm sorry at the cost of embarrassing Durga, because I've already, greeted him the usual way we greet each other. And I'm very proud to be introducing this wonderful surgical oncologist to you with a with a passion for whatever he does, whether it is hepatobiliary surgery. I mean, he's the most animated person you could ever come across, because that's what passion does to you. You could be describing something very innocuous, and you could still go overboard about it, and that really defines Dr. Durgatosh Pandey. To me, he's always been Durga, and I've known him for how many years now, Durga? 26 years, I would say. 26 years is a long time. It's about definitely more than what do you call 30% of your lifetime. So that's just amazing. And what I know of Durga is I was just telling you that he really borders close to being a genius. He is a genius as far as I'm concerned. He's got a photographic memory, something that anybody would want to, to own. And don't go by his, everybody, once, somebody meets Durga, because, he's so passionate, you could mistake it for aggression, because obviously he tries to put his point across very vociferously and vehemently, because he believes it to be right. But then there is an equally strong spiritual aspect to it, to him. And the kind of, what do you call, the kind of thinking that goes into his interpretation of a lot of scriptures is just amazing. And I have just skimmed the surface, and I know, wow, that's a great outlook. So if anybody gets an opportunity to interact with this gentleman, he is a real powerhouse of knowledge and a well-rounded source of knowledge. So I'm sure you will gain a lot from today's lecture. I'm looking forward to it. Although I told Durga, look, my interest in liver is close to nil. And your moderator is Dr. Vivek Mangla, and we all share our institutions, and that is the common institution being Maulana Azad Medical College. And Dr. Vivek Mangla is also he's a GI surgeon. He's joined us as associate director of GI oncosurgery, and he will also have, I'm sure he'll have plenty to share as we go along. So please stand by for an excellent lecture. I'm sure nobody would want to miss it. So over to you, Durgatosh, Dr. Durgatosh Pandey.
Thank you, madam, for that kind introduction. And can we start now?
Yes, sir. You can share your screen, sir.
Okay, all right. How do I do that? Share the screen.
Yes.
Yes.
Multiple participants can share instantly.
No. Sir, press the green one, not the arrow. Press the green one, not the arrow. You're going to the arrow.
So green I am pressing and nothing is coming.
It should come.
Desktop 1.
It'll take you to your desktop.
Desktop 1.
Hanji.
Desktop 1, and your thing is coming. So how do I do it?
Your PPT is on your desktop?
Yes.
Sir, please open that PPT.
No, but desktop on my screen, Shubham's screen is visible. I can see Shubham's screen.
No, तुम्हारा desktop आएगा दुर्गा.
नहीं है ना?
Desktop 1 आ रहा है ना?
Desktop 1 में अभी आपका फोटो आ रहा है.
No, desktop 1 को click.
नहीं.
Now it is there. Okay.
Yeah.
Fine. So is this visible?
It is visible, sir.
Yeah,
is my screen visible?
Your screen is visible.
Yes.
Okay.
Absolutely.
Yeah.
So
Okay.
my screen is visible, is it?
Yes, sir. It's visible.
So we'll start. Today's topic is surgical basis of liver resection. Till this morning, I was under the impression that I have to only speak about the anatomical basis of liver resection. But now the topic becomes a little broader. So let's see how it goes. So all organs are unique in their own way, but liver is a unique organ by its anatomy, as well as its physiology, and we'll discuss about all those things. And it is a unique organ because of its anatomy, because it has got a dual blood supply. It has got two afferents, and the maximum amount of blood comes through the portal vein, and the smaller quantity of blood comes through the hepatic artery. Just hold on for a moment. I'm just coming. Sorry. So there are two afferents, portal vein and the hepatic artery, and there are three efferent veins, predominantly three efferent veins. These are the hepatic veins. Also, it is a unique organ because of the segmental anatomy of the liver. And each segment has its own inflow and outflow, as well as the biliary drainage. Now, before going to the hardcore segmental anatomy, we should know something about the external anatomy of the liver. And here we have the peritoneal attachments and ligaments. I'm sure most of you would be familiar with. So we have the right and the left triangular ligaments, right and the left coronary ligaments. We have the falciform ligament, ultimately where the umbilical ligament goes. And these are basically the ligaments. And the bare area of the liver, which was such a dreaded question during our anatomy period, is nothing but actually a non-peritonealized surface of the liver, which is mostly between the right triangular ligament and the right coronary ligament. That's the biggest bare area. There's a little amount of bare area on the left side as well. As we see in this picture, the gallbladder is here, and on the posterior aspect, the inferior vena cava forms a very intimate kind of a relation with the liver. So as we discussed, the inferior vena cava actually forms a very intimate relation with the liver, and knowing this relationship is extremely important. Here, the liver has been rotated towards the left side, and as we can see, this is the inferior vena cava, and the dissection generally proceeds from the right triangular ligament from the inferior aspect. Sometimes the adrenal vein is seen and can be saved. Occasionally, if there is an injury, we can repair it. The ligation of small little tributaries which are anterior to the IVCs can be done, and then we approach what is called a hepatocaval ligament. This hepatocaval ligament is a paracaval condensation to the right of the IVC, which actually hides the right hepatic vein. So once this is released, the right hepatic vein comes into the full view. Now, as we speak about the outflow, that is the IVC, towards the IVC, we also should come towards the hilum of the liver, that is the inflow. And this is also a unique situation in the liver, where the inflow actually is surrounded by what is called a Glisonian sheath, Glisson sheath. This is nothing but a facial condensation in form of a sheath continuing intrahepatically. And it encases the three elements at the porta hepatis, the hepatic artery, the portal vein, and the bile duct. As they branch, they actually branch within the branches of the hilar plate. The hilar plate also, the Glisson sheath also branches into the liver, and it goes right up to the segmental anatomy. The branches of the portal vein, the hepatic artery, as well as the bile duct are encased within this Glisonian sheath. So the application of this is that we can actually follow this Glisonian sheath into the sectoral branches, into the segmental branches as well. Now, there is something called a hilar plate. Now, it's nothing but actually what it is a condensation, this Glisonian sheath where it meets the liver. So we just separate the liver parenchyma from the Glisonian sheath, and this is what is called taking down of the hilar plate. Once the hilar plate is taken down, then we actually have dissected the Glisson sheath of the liver. And then we can follow the Glisson sheath and go into the liver and get into the sectoral and segmental anatomy in that sense. So there are three hepatic veins, and the liver hangs from these veins. There is no other major vasculature between the anterior surface of the IVC and the liver. And this is the premise of the so-called liver hanging maneuver, which we will discuss later. That's the CT image of the three hepatic veins. We have the right hepatic vein, the middle hepatic vein, and the left hepatic vein all arising from the IVC, and the liver actually hangs from there. In this picture, the liver has been rotated. We can see the IVC here. The right hepatic vein has been looped here, and this thread, this umbilical tape, is running just anterior to the IVC. And when the liver is derotated, it falls on the liver, the right surface of the liver. I mean, the junction of the right and the left falls on this umbilical tape, which can be used as a guide to resect. Next, the principal plane, or what is called a Cantley's plane, Cantley's line. Now, this is the principal plane which is dividing the liver into two halves, the right liver and the left liver. And in a normal human body, in a supine position, it is at an angle. And this principal plane actually passes from the gallbladder fossa to the inferior vena cava. And on this principal line, the middle hepatic vein lies. So the division of the right and the left lobe of the liver, functional division, is by this Cantley's line. And if we go into it a little more deeper, then the middle hepatic vein actually divides the right and the left liver. Now, when we come to the sectors and segments, the three hepatic veins will divide the liver into four sectors. And the plane of the portal vein divides these four sectors into 8 segments. Now, we have to understand this a little bit. So, we have the three hepatic veins. On the right of the right hepatic vein is the right posterior sector. Between the right hepatic vein and the middle hepatic vein is the right anterior sector. Between the middle hepatic vein and the left hepatic vein is the left medial sector, and the left of left hepatic vein is the left lateral sector. So if we see it here, so this one is the right hepatic vein, the RHV. Here we have the middle hepatic vein, and the right hepatic vein, right to it is the right posterior sector. Left to it, that is between the right hepatic vein and the middle hepatic vein, is the right anterior sector. Between the middle hepatic vein and the left hepatic vein is the left medial sector, and left to the left hepatic vein is the left lateral sector. Now it is again divided by the portal plane. And what is this portal plane? Where the portal vein actually goes into the liver and then it starts dividing in that plane. So that's the portal plane, and it will divide into the 8 branches, each sector into 2 branches, 2 segments. So we have 4 sectors and we have 8 segments. So here we see that superior to the portal plane in the left lateral sector, we have segment 2, then inferiorly it is segment 3. Left medial sector is completely composed of segment 4, which is 4A superiorly and 4B inferiorly. The right anterior sector or section is also called sections in some places. So it is right anterior sector is segment 5, which is inferior, and segment 8, which is superior. And right posterior sector is segment 6 and 7, which is 6 is inferior and 7 is superior. So in a clockwise direction, if we move segment 2, 3, 4, 5, 6, 7, and 8. This is how from the left to the right side, we move in a clockwise fashion, and this is how the segments are mentioned. And how do we divide the segments? First, we should know that we have to define the sectors. Once we have defined the sectors according to the distribution of the hepatic veins, then based on the portal plane, whatever is inferior to the portal plane will have segments 3, 4B, 5, and 6. Superior to the portal plane will have segment 2, 4A, segment 7, and segment 8. If this is clear, we will discuss at the end of the talk a very easy way of remembering these things. Now, this is the segmental anatomy, which was proposed by Conrad in 1954. This shows the same picture in a 3-dimensional way. So segment 2 and 3, which is left of the left hepatic vein, and segment 2 is superior to the portal plane, and segment 3 is inferior to the portal plane. We have segment 4, which is between the left hepatic vein and the middle hepatic vein. The superior part is segment 4A, inferior is 4B, again divided by the portal plane. We have segment 5 and 8, which forms the right anterior sector. Again, 5 and 8 are divided by the portal plane. And where do this 5 and 8 lie? The right anterior sector between the middle hepatic vein and the right hepatic vein. And then on the rightmost side, that is on the right side of the right hepatic vein, we have what is called the right posterior sector, which is segment 6 and 7. And 6 and 7 are again divided by this portal plane. Now, how do we define the segments, identify the segments on CT scan? It is not difficult. We follow the inferior vena cava first. Now, once we see the inferior vena cava, we can see the branching of the inferior vena cava into the right, middle, and left hepatic vein. Now, as we have seen that the sectors of the liver can be defined by these divisions. Right to the right hepatic vein is the right posterior sector. Between the right hepatic vein and the middle hepatic vein would be the right anterior sector. Between the middle and the left hepatic vein would be the left medial sector, and left to the left hepatic vein would be the left lateral sector. So this defines our sectors. Now, as we go down, we will see the portal vein coming. Here we can see the portal vein coming. This is the portal plane. Now, whatever is superior to the portal plane and whatever is inferior to the portal plane, we will define the segments in those sectors accordingly. So going back to this slide, the on the superior cuts, what will we see? We will see segment 2, segment 4A, segment 8, and segment 7. And in the inferior cuts, what would we see? We'll see 3, 4B, 5, and 6. So this is how we identify the segments on the CT scan. The caudate lobe is a separate lobe by itself, and it is the segment 1. So we have 8 segments. Actually, functionally, if we see, we have 9 segments. The segment 4 is actually 2 segments, segment 4A and 4B. But we have, we tend to call liver as an 8-segmented organ. So, okay. So this caudate lobe is segment 1, which is an independent unit between the IVC and the portal triad. So its location is between the IVC and the portal triad. So it is very densely populated by the vessels around it. So that's a dangerous area to dissect. So the IVC would be posterior to it, the portal triad would be anterior to it. It receives independent supply from the right and the left portal veins. So we have the right portal vein and the left portal vein, which will independently give small branches to this caudate lobe. It has independent drainage through small veins directly into the IVC. So the caudate lobe would not drain via the right or middle or left hepatic vein. Rather, it would drain directly into the IVC via small tributaries. Now we go to the first order division. What is the first order division? First order division is by the middle hepatic vein, which divides the liver into right liver and left liver. Right liver is composed of segments 5, 6, 7, and 8. And left liver is composed of segments 2, 3, and 4. Remember that segment 1, which is the caudate lobe, is an independent entity. So the surgical resection of the right liver is called right hepatectomy or right hemihepatectomy. If we resect the segment 1, that is caudate lobe, along with the right hepatectomy, it is called right hepatectomy plus segment 1 resection or plus caudate lobectomy. This is a very common procedure which is performed for hilar cholangiocarcinomas. Similarly, the left side, left hemiliver or left liver, what is it? Segments 2, 3, and 4. And the corresponding surgical resection is left hepatectomy or left hemihepatectomy. If we include the caudate lobe along with left hepatectomy, it is called left hepatectomy plus caudate lobectomy or plus segment 1 resection. Once we go into the second order division, these are more uncommonly performed procedures. The right anterior sectionectomy, which is segment 5 and 8, which is the right anterior sector or section, and the corresponding resection is called right anterior sectionectomy. Right posterior sectionectomy is the resection of segment 6 and 7, which constitutes the right posterior sector or section. Left medial sectionectomy is resection of segment 4, which is segment 4A and 4B, which forms the left medial section. Left lateral sectionectomy is, or bisegmentectomy 2 and 3, is the resection of segments 2 and 3, which is the left lateral section. So this is the second order division. Am I audible? Hello?
You're audible, so perfect. It's going wonderful.
All right.
You're audible, Durgatosh.
All right. Please feel free to interrupt me and ask questions whenever there is a confusion or whenever you think I'm making a mistake. The next type of liver resections is basically extended liver resections, what we call. The preferred term would be right trisectionectomy or a right extended hepatectomy, extended right hepatectomy. What is it? It is right hepatectomy plus segment 4. That means right trisectionectomy or right hepatectomy. Trisectionectomy, remember, posterior section, right posterior section, right anterior section, left medial section. That is why trisectionectomy. Left trisectionectomy is left hepatectomy plus the right anterior sector, that is segments 5 and 8. So these are the procedures, the extended hepatectomy which are performed. In this kind of a three-dimensional picture, same, and nothing really great. This is a right hepatectomy on the top, right extended right hepatectomy in the bottom, which includes the segment 4 with plus right. Same with the left hepatectomy segments 2, 3, and 4, and the left extended left hepatectomy includes the right anterior sector, that is the segments 5 and 8, along with the left hepatectomy. The central hepatectomy. This is another uncommonly performed procedure. Sometimes we do it for advanced gallbladder cancers, which are going into, or occasionally for hilar cholangiocarcinomas also. Although if for a hilar cholangiocarcinoma, it really becomes a very challenging reconstruction after the resection. Resection itself is a challenging procedure. Reconstruction, multiple bile ducts will be available to anastomose. So this central hepatectomy is a combination of resection of left medial sector, that is segment 4, and the right anterior sector, that is segment 5 and 8. So this middle part of the liver is removed, and this is what is called a central hepatectomy, or sometimes a median hepatectomy. Some people have given a very exotic name of Taj Mahal resection to this kind of a resection. Now, after this anatomy, we come back to the physiology. Now, those of you who would know this mythological story, the Greek mythological story, Prometheus actually stole fire from gods and gave it to men. And for this, the Greek god Zeus became very angry with Prometheus, and he punished Prometheus. And how was he punished? He was chained to a rock, and Zeus sent an eagle who would eat his liver in the daytime. The liver would regenerate at night, and the eagle would eat the liver the next day again. So probably the ancient Greeks were aware about the regenerative capacity of the liver. But more importantly here, they used to think that liver is a seat of emotions. This was what the Greeks used to think. And it's not an uncommon thinking. Even if you look into the Hindi word for liver, and which has come actually from the Persian language or an Arabic language, I'm not sure, that is jigar. So your son or a daughter, your child becomes jigar ka tukda. Your best friend becomes jigri dost, right? Your girlfriend becomes jane jigar. Although after a few years, maybe of marriage, it will become, you will jigar tham ke baithoge jab wo aayenge to. So the liver is was usually considered as a seat of emotion, and to punish Zeus for this emotional act which he did, that is an act of stealing fire, Zeus gave him this punishment. And this is an indication of the regenerative capacity of the liver, and which is the basis of liver resection. You can actually resect a lot of liver. If the patient bears through the initial post-operative period, the liver regenerates to 80 to 90% of its volume, and then the patient can lead a normal life. So that's the basically fundamental basis of liver resection. So safe liver surgery is basically a balance between an adequate resection with margins and assessment of an underlying hepatic function or its impairment. And this is extremely critical to select patients for liver surgery. So we have to take care of the resection part. We have to know how much part we have to resect. We also have to know what is the baseline functional capacity of the liver, or what are the impairments in liver function in the baseline. So how do we do it? There is no single way of doing it. For a normal liver with a, let's say, hepatocellular carcinoma within a non-cirrhotic patient, great investigations are not required. Straight away, we can plan the resection part after the usual PSC investigations. What becomes problematic is when the patient has a chronic liver disease, when the patient has an impaired liver function. So we have to actually do some child Pugh score. Everybody knows this. Portal hypertension assessment. We have to, sometimes a functional assessment like a dynamic test with indocyanine-Green or nuclear scintigraphy is also done. But most often, the child Pugh score, which is a very common tool used by everybody, and some assessment about portal hypertension should be done in cirrhotic patients. Now, portal hypertension, child Pugh score, I don't need to reiterate, but portal hypertension assessment is a little subjective. Some people do it very objectively by doing a hepatic venous wedge pressure for all their patients. I know of some institutions which do that. If the pressure is above 12, then do not operate. If it is between 8 and 12, then the risk is stratified accordingly. If it is less than 8, then the patient does not have much problems after liver resection. But most of us do not do that hepatic venous wedge pressure. So how do we assess for the portal hypertension? If you ask me, how do I assess? So I have 3 factors: splenomegaly, platelet less than 1 lakh, and grade 3 varices on endoscopy, grade 3 esophageal varices. If 2 out of 3 are there, do not operate. The patient has got a severe portal hypertension, will not be able to sustain this kind of a injury to the resectional part. If 1 out of 3 is present, then a little complicated surgery, but can be done. If none of 3 are present, then go ahead and do the surgery. The portal hypertension is not much. Now, after assessment of this Child-Pugh score and the portal hypertension, sometimes if the liver tumor is a large tumor or an anticipated resection is large, then we need to have a volumetric assessment for functional reserve. Now, what is this volumetric assessment? What is the purpose of the volumetric assessment? So, it is the FLR which we are bothered about. We are focusing on the future liver remnant. And what is this future liver remnant? It is the ratio of the resected liver, remnant liver volume to the total liver volume. This was the historical definition. The historical definition was the ratio of remnant liver volume to the total liver volume. This was the FLR. And it was said that it must be more than 25% in non-cirrhotics. On the safer side, it must be about 40% in non-cirrhotics and 60% in cirrhotics, if we have to be really safe. But more than 25% in non-cirrhotics and more than 40% in cirrhotics, it is a doable situation. Now people have moved away from that definition, and it now includes, it actually says that ratio of remnant liver volume to the functional liver volume, to the total functional liver volume. Why functional liver volume becomes important? Suppose there is a very large tumor on the right lobe of the liver. That volume of the liver which is occupied by the tumor is a non-functional liver. So from the denominator, we have to subtract the tumor volume. So the total liver volume minus tumor volume becomes the functional liver volume. And then if we do that, and once the denominator is reduced, then more patients will become candidates for hepatectomy. So this is what is the definition of a future liver remnant. Now people have moved further away. They say now that the ratio of the remnant liver volume to the body weight, that is the remnant liver volume to body weight ratio, could be a better option for assessment. And this ratio should be more than or equal to 0.5%. If it is less than 0.5%, then they are at a considerable risk for hepatic dysfunction and post-operative mortality because of post-operative liver failure. Now, types of resection: non-anatomical resection and segmental oriented liver resection. The non-anatomical resection is the clear-cut. Most often we do it for a gallbladder cancer which has not invaded much into the liver. The non-anatomical resection in this situation would aim only at taking some margin. The anatomical resection would be right hepatectomy. We have already discussed that. Right extended hepatectomy, the corresponding photographs are being shown on the right side. Left hepatectomy, left extended hepatectomy, median or a central hepatectomy, and then we have segmental resections. Now this is a picture showing an extended right hepatectomy for hilar cholangiocarcinomas. And as we can see, this is the end of the procedure actually. The Roux-en-Y hepatico-jejunostomy, so done in this. So I showed this picture only to say that, as we discussed, central hepatectomy could also have been done in this particular situation, but then the reconstruction becomes so difficult. There are 2 or 3 more biliary channels to be anastomosed here. This one is again a right hepatectomy. The previous one was extended right hepatectomy for hilar cholangiocarcinomas. This one is a right hepatectomy for hepatocellular carcinomas. This is easier because it does not require any further reconstruction. You resect the organ and that's it. So if we can see the IVC somewhere here, and this is the left lobe of the liver, which is there. Now let us go towards the classification according to the surgical technique or an approach. So pedicular clamping, we will discuss in the subsequent slides, or a Pringle maneuver. Classical preliminary vascular section, the anterior approach, that is primary parenchymal transection without any control of inflow or outflow. The hanging maneuver, the total vascular exclusion, and the Gleasonian approaches. These will be discussed in subsequent slides. So Pringle described pedicular clamping more than a century back. So this Pringle maneuver is a very, very commonly done procedure. It is every surgeon is well versed with this kind of a technique. So this interrupts all inflow to the liver, but leaves intact outflow. In healthy non-cirrhotic liver, the intermittent clamping of up to 30, actually it is 30 minutes, is supposed to be well tolerated. But for safety's sake, we do 15 minutes on and 5 minutes off. In cirrhotics, an alternating cycles of 10 minutes clamping and 5 minutes declamping is done. So what is the positive aspect of this? We have a vascular control and we have a reduced blood loss. The negative connotation, ischemia to the normal liver and impaired hepatic function. Actually, in non-cirrhotics, it doesn't matter. In post-operative period, we can have transaminitis. We can have AST and ALT raised by to 500 or maybe 800 or 1000 also. It really doesn't matter. It absolutely does not matter in a non-cirrhotic patient if we can make the surgery safer by this. The next method was a classical method of a preliminary vascular section. Now, what is this classical method? This is, suppose we are doing a right hepatectomy. Then it consists of ligation of the Gleasonian pedicle on the right side. Followed, which means that the ligation of the portal vein, the right hepatic artery, and then it is followed by the ligation of the right hepatic vein as well. Ligation of the right hepatic. So it is a total hemi-liver exclusion, vascular exclusion. This is the classical method, which was described by the Lauder, Jacob, and Robert long time back. So the advantage, they say that there is a good demarcation because of devascularization, leads to a reduced blood loss. But it is unsuitable for bulky tumors in proximity to the inferior vena cava or the tumors with a diaphragmatic invasion. There is a real risk of injury to the hepatic veins, and there may be congestion due to outflow obstruction. The next method was total vascular restoration. This is even radical method of liver resection. It is now just historical. I don't know of anybody who follows this method as of now. So this total vascular exclusion used to be, the liver has to be mobilized fully. After mobilization, we clamp the entire portal pedicle by the Pringle's maneuver, the vena cava above the liver and the vena cava below the liver. So once this is done, the liver is isolated. There is no blood flow in or out of the liver. And the theoretical premise was that in a devascularized liver, you can easily resect and then quickly resect and achieve hemostasis. But there are problems. The problems used to be that the anatomical margins are not visible, especially for extended hepatectomy. There is a real risk of injury to hepatic veins or retrohepatic vena cava, which can go unnoticed until the perfusion is reestablished. There is a very high degree of hepatic ischemia and impaired liver function. So this method has been practically given up. I have never followed this method. I do not know of anybody else who has followed this method. This is the anterior approach, which is the primary parenchymal transection, which was described by Tontat as well as Uzawa. And to begin, there is no control of the inflow or the outflow. One straight away begins with a parenchymal transection. Now it avoids the rotation of the lobes and the displacement of the lobes, which impairs circulation. This was the premise. Everything is ligated and transected intraparenchymally during the parenchymal transection. Once, as and when the vessels come, they are transected. So it excises an amount of parenchyma as per demand, the ligation of vessels is not hampered by anatomical abnormalities, because as we proceed through the parenchymal transaction, whenever that vessel comes, it is ligated, and it is quite suitable for large tumors. The problem is that because of a lack of preliminary vascular control in the inflow as well as on the outflow, there is a chance of increased blood loss. So there was a modification to this anterior approach, which was called a hanging maneuver. Again, it is a kind of an anterior approach only, but this was a hanging maneuver. Now, this was described by Belghiti, and what did he describe? He said that anatomically there is no major vessel between the inferior vena cava and the posterior surface of the liver. So just as we do a tunneling in case of a Whipple's operation, that was the statement which was made, that just as we do a tunneling between the posterior aspect of the neck of the pancreas and the portal vein in a Whipple's operation, similarly a tunneling can be done between the inferior vena cava and the liver. And in this tunnel, a vascular tape or an umbilical tape can be passed, it can be pulled up, and the anterior approach of liver resection, parenchymal transaction can be applied to this. This was the classical technique of a hanging maneuver. Now, most people do not follow this classical technique. Why? Because it is that plane is not always avascular. There are some small little veins which go into the vena cava, and when they bleed torrentially. And if a tumor is near the inferior vena cava, then again, the chances of these small little veins being there is even higher. There is a chance of injury to inferior vena cava. That is why this classical method of hanging maneuver is seldom followed. What do we follow? We follow a modified technique of a hanging maneuver, in which, if we are doing a right hepatectomy, mobilize the right liver completely, dissect it off the IVC, ligate and transect some of these small little branches from the IVC to the right lobe of the liver, try to loop the right hepatic vein, and then the same umbilical tape can be passed downwards, and it can be used for hanging once the liver is left in its anatomical position. So that is a modified technique of a hanging maneuver. The pros of this is it makes the anterior approach easier and safer. It protects the IVC. The vertical transaction along the shortest possible route is possible. And what is the disadvantage? It is unsuitable when an avascular plane is infiltrated, probably by a large tumors in cirrhosis, when there is a diaphragmatic infiltration, etc. Right? So this is what is the hanging maneuver. The next one came hepatectomy with a Glisonian approach. Now this Glisonian approach became more popular in Japan and the Asian countries, Eastern Asian countries, where the segmental resections were done more often than what was done in the West. So what is this Glisonian approach? This was described by Takasaki. First, the hilar plate is taken down. After taking down the hilar plate, the detachment of primary Glisonian pedicle is done from the liver parenchyma, and a selective clamping of segmental branches can be done to achieve demarcation or devascularization of the affected segments. Now, as we can see in the picture, this Glisonian capsule actually encases all these portal triad along with its branches. So this can be followed right into the liver parenchyma, and this is the Glisonian approach. And whatever segment one has to resect, people have gone into sectoral resection, segmental resections by purely following this Glisonian approach. Advantage is it is a super selective segmental pedicle clamping resection, and it limits ischemia to the remnant liver, and it is a very important tool for cirrhotics. Now, once this the approach to the liver resection is done, we come towards the parenchymal transaction. Now, vascular control can be done with inflow as well as outflow control. Outflow control, very often it is not done. Inflow control is more often practiced. And the dissection techniques and the devices, there are several techniques and several devices, each surgeon to his own. The historical thing was a finger fracture method. And this finger fracture method actually gave way to clamp crushing or cheliclasis. remember that the two jaws of the Kelly are actually two fingers used in a similar way. The finger fracture is almost the same as cheliclysis, except the fact that the fingers are broader, the Kelly is narrower, and therefore it has more control. We have ultrasonic dissection, that is with CUSA. We have hydrojet dissection. The energy devices can be used. The harmonic can be used, LigaSure, Thunderbeat, the Habib knife, which is an RFA-based device. The vascular staplers can be used. There is absolutely no evidence to suggest that using a specific equipment for liver resection benefits by decreasing morbidity, mortality, or blood requirements. It is absolutely a matter of personal preference. So I have never used hydrojet dissection. I have never used Thunderbeat or Habib knife. Occasionally, I have used vascular staplers for parenchymal transection. Most commonly, I have followed this cheliclysis. This is the commonest for me. It is a very simple method. It's a very quick method. It is a very easy method to learn. With the advent of harmonic, actually the two jaws of harmonic can be used as a Kelly. And when we see that a very small little vessel is there, we can actually use that harmonic as an energy device. Otherwise, we can use the harmonic as a cheliclysis and proceed. This is for as far as the tumors are concerned, tumor resections are concerned. Probably for a transplant situation where a right hepatectomy in a donor is being done, CUSA is probably a better method because both sides are important now. The side which is lying down, which is left behind in the donor, and the side which is being resected and being transplanted in the recipient. Because both are important, therefore CUSA will be a slightly better alternative to cheliclysis. That's my opinion. But for a resectional part, cheliclysis is much faster. To me, it's a much better method than any others. So this is how the cheliclysis works. The Kelly, when we crush, this is a clamp crushing method. It actually divides the liver parenchyma, but it does not divide the hepatic veins or the portal triad branches. So once they come, then if they are very small, less than 0.3 millimeters probably, you can actually burn them or use a harmonic or just cut them off. If they are a little bigger than that, then clip them or ligate them and then cut it. And we can proceed very quickly into the liver by the cheliclysis method. This is CUSA. Again, a very good method for people who are very conversant with this. The hydrojet, the vascular stapler. Vascular stapler, I have used it only for left lateral sectionectomies, segment 2-3 bisegmentectomies. Otherwise, I find it, I'm not comfortable in applying this vascular stapler for a right hepatectomy. Now let's come to the complications. After major liver resection, the mortality should be less than 5%. The morbidity is, however, significant, which can be anywhere between 30 to 45%. Now these are the three most common and dreaded complications: hemorrhage, bile leak, and post-hepatic liver failure. Now hemorrhage is a very dreaded complication, and remember, and this is for the junior people who would be listening, in a liver resection, if you see that there has been an intraoperative death because of hemorrhage or immediate post-operative death because of massive hemorrhage, it is never from the portal vein side. It is always never from the hepatic artery side. It is always from the IVC side. So hepatic veins are notorious for bleeding. So that control one must have. And there are measures to reduce blood loss. How? We should select the cases and optimize those case selections. The cirrhotics are known to bleed more than non-cirrhotics. The portal hypertensives are known more to bleed than the non-portal hypertensives. Then intra of what maneuvers can we do? Inflow control, outflow control, and low CVP. Now inflow control is a very common thing which is practiced. Even outflow control, but most commonly it is given up because it sometimes causes more congestion than and causes more disadvantage by congestion than advantage it gives. So inflow control is either by intermittent porta clamping or by selective ligation or division of inflow vessels or by Glisonian approach, which we discussed before. So if we are doing a right hepatectomy, let's say, try and dissect in the hilum, get into the right side of the Glisonian capsule, remove the gallbladder, we can see the right hepatic artery behind, most often behind the bile duct. So right hepatic artery can be divided. This will give you some demarcation on the liver. Try to dissect the portal vein and to its division. And if we can see a stump of the portal vein on the right side, either staple it or divide it. So once that is done, the inflow control, the selective inflow control is established. If that becomes difficult, sometimes that becomes very difficult in patients who are cirrhotics, or maybe in whom the tumor is close to the porta hepatis. In those situations, do not try to do that if it is very risky. Intermittent porta clamping is a safe method. Don't bother about the post-operative rise in transaminases. It really doesn't matter. Okay, so either by Pringle maneuver or by selective ligation or division of inflow vessels, sometimes by Glisonian approach. This is how the inflow control is established. So here we see that this is the portal triad clamping, which is the Pringle maneuver. It contains all the parts of the porta hepatis, which is the bile duct, the portal vein, and the hepatic artery. And here we have the selective ligation. The right hepatic artery is here. It can be divided after ligation. The right portal vein and the right hepatic duct. Hepatic duct can be divided later. It doesn't matter. So right portal vein and right hepatic artery, if it is divided, we are ready for a right hepatectomy. The next method is CVP reduction. You remember that I reiterated that most of the massive hemorrhages happen from the IVC side, which means that the venous pressure, the systemic venous pressure, if it can be reduced, then theoretically the blood loss from the venous side can be reduced. But it has become a contentious issue. I do not know why. There are surgical means of CVP reduction, which is by IVC cross clamping, which is a dangerous method. And there are anesthetic means of CVP reduction. So if the anesthesiologist is your good friend, then half the liver resection is over. It becomes a much simpler procedure. By head tilt, the reduced PEEP, giving glyceryl trinitrate, reducing the volume which is being given, and the use of diuretics. These are the means to reduce the CVP. Why it has become contentious is because of this meta-analysis. There have been studies, and there was a meta-analysis which was published in 2015. Look at the conclusion of the meta-analysis. This was published in HPV Journal 2015. It says that low CVP surgery is associated with a reduction in estimated blood loss. However, this does not translate into an improvement in post-operative morbidity. So because of this line, people started saying that probably central venous pressure reduction is not so useful. The problem again is that people tend to just look at the abstract without reading in detail of the paper. Now, 8 studies were selected, 8 trials were selected. Let us go. First four trials were by the anesthetic means of reducing the CVP. So these are okay, right? The next 3 are actually by surgical means. And this is dangerous. Why? Because it leads to a greater deal of ischemia. It leads to greater deal of a thromboembolic phenomenon. It leads to a greater incidence of renal dysfunction. So the advantage which we have by reduced CVP is lost because of those complications. Secondly, if we look at the control arm, so the first 4 is fine. The first 4 controls are really controls. But the next 3, if we see, the control is actually the anesthetic means. If we look at the fifth paper by Rahbari et al., the experimental protocol is by surgical reduction of CVP, and the control protocol is by anesthetic reduction of CVP. So why this paper was included, I do not know. If we look at the CVP, it was more in the experimental protocol arm, that is 4, and lesser in the control arm, that is it was 2.6. The last study which was included, it was basically a comparison between a complete inflow occlusion and the selective inflow occlusion. Now, again, why this was selected for CVP reduction, we don't know. So if we look into this paper, 4 out of these 8 studies are actually should not have been included because they are with surgical, either they are with surgical means of CVP reduction, or it was not an attempt at CVP reduction. It was actually a complete occlusion inflow control versus selective inflow control. Only these 4 should have been included. So this was never taken into account, and therefore low CVP anesthesia during liver surgery has become now a contentious issue. But I am very much convinced low CVP anesthesia will lead to less blood loss, and less blood loss by itself is an important endpoint. And as we can see that less blood loss is associated with lower mortality, lower incidence of post-hepatic liver failure. Now the next complication, post-hepatectomy bile leak. Bile leak can be from a transected surface of the liver. It can be from a bilioenteric anastomosis if it is done for, let's say, hilar cholangiocarcinomas. It can be because of an inadvertent injury to a major biliary radicle or a duct. The incidence in hepatectomies is up to 3% without major reconstruction, and with reconstruction it is up to 8%. The definition here is not by volume. The definition we should remember is by the drain fluid bilirubin. So if the drain fluid bilirubin is more than 3 times the serum bilirubin concentration after the day 3, or if there is a radiological intervention for biliary collection, or if there is a need for re-laparotomy for a biliary peritonitis, this is bile leak. We do not include the volume of leak because it is often confounded by ascites. There are grades of bile leak. In grade A, there is no real change in clinical condition. Nothing needs to be done except retaining the drain. The patient can be managed as an outpatient or in the surgical ward. The grade B, the patient manifests with tachycardia, fever. Sometimes an image-guided pigtail or an ERCP stenting or a PTBD may be required. Antibiotics may be prolonged, managed in surgical ward. The hospital stay may be prolonged. Grade C, the patients are sicker. It may lead to hemodynamic instability or sepsis. Re-laparotomy, clearing the collections, bilioenteric anastomosis may be required. Antibiotics are stepped up. The patient is generally managed in the ICU and the hospital stay is really prolonged. Now we come to the third and the most dreaded complication, which is post-hepatectomy liver failure. This is the commonest cause of death in post-hepatectomy patients. Early deaths are because of hemorrhage. Later deaths are mostly because of post-hepatectomy liver failure. Now the incidence in healthy livers are up to 2%, but with major resection, it can go up to 7%. For cirrhotics or with pre-existing chronic liver disease, it is 0 to 10%. For major resections, it can go up to 30%. What are the risk factors? The risk factors can be patient-related, surgery-related, and post-operative factors. The patient-related factors are the systemic factors like comorbidities, obesity, diabetes, COPD, renal failure, malnutrition. If the patient has been given chemotherapy, because nowadays the metastectomy for colorectal cancers, major liver resection for metastectomies has become quite common now. So chemotherapy-associated steatohepatitis, which is CASH, the hepatitis B, C, or cirrhosis due to any cause, the bilirubin more than 10 milligram percent, some people say more than 8 milligram percent for hilar cholangiocarcinomas. So if the patient of hilar cholangiocarcinoma has a bilirubin which is more than 8 or 10, it is probably better to reduce that bilirubin by PTBD or by some kind of a ERCP method before going in for a major liver resection. Then there are surgery-related factors. If after the liver resection, there is a small for size liver, which is an inadequate FLR. If the blood loss is more than 1.5 liters, if there is a need of blood transfusion, which is more than 3 units, the duration of surgery is more than 4 hours. Duration of surgery is not from skin to skin, but the part of the liver, when you are on the liver, it is more than 4 hours. The need of vascular reconstruction, these are surgery-related factors. Post-operative factors, post-operative infections, post-operative hemorrhage or bile leak can contribute to post-hepatectomy liver failure. Now, it manifests as hyperbilirubinemia, increased drain output, that is because of ascites, prolonged INR, hypoalbuminemia, and in severe cases, patients have hypoglycemia, renal failure, and sepsis. Again, like it has been graded, the post-hepatectomy liver failure, grade A, B, and C. The grade A results in an abnormal laboratory parameters, but requires no real change in the clinical management. Grade B requires a deviation from regular clinical management but is manageable without invasive treatment. Grade C requires invasive treatment. And this is what the grade A, B, C are. The clinical symptoms may not be much. There may be a little more increase in the drain fluid, which is because of ascites. It is managed in ward. No intervention is required. No mortality. Grade B, the ascites is more. It may lead to weight gain. It may lead to mild respiratory insufficiency, and there may be some amount of hepatic encephalopathy. It is managed in HDU. The interventions are usually non-invasive by plasma, albumin, diuretics. Sometimes the patients may require non-invasive ventilation, and ultrasound or CTs and other methods may be required. The mortality is up to 12%. Grade C, the patients are much sicker. It results in hemodynamic instability, respiratory failure, renal failure, encephalopathy. The patients are in the ICU. Invasive intubation may be required. Hemodialysis occasionally, inotropes, IV glucose supplementation for hypoglycemia may be required. And this carries a mortality of up to 50%. So this is the 50-50 criteria on post-operative day 5. After major hepatectomy, on post-operative day 5, if the serum bilirubin is above 50 micromoles per liter, and the conversion of micromoles per liter to milligram per deciliter is 17. So milligram per deciliter multiplied by 17 is micromoles per liter. So if it is more than 3 milligram per deciliter or 50 micromoles per liter, and the prothrombin time is more than, this is less than we have written, it is more than 50% of the baseline. This is the 50-50 criteria, more than 50 micromoles per liter bilirubin and prothrombin time more than 50% of the baseline on postoperative day 5. This is a predictor of mortality and other complications in up to 70% of the patients. What are the measures to reduce the post-hepatectomy liver failure? Again, case selection. The patients, then adjunct modalities like preoperative TACE or even portal vein embolization should be tried to increase the FLR in order to reduce the post-hepatectomy liver failure. Preoperative biliary drainage in hilar cholangiocarcinomas, as I mentioned, if the bilirubin is more than 10 in hilar cholangiocarcinomas, preoperative PTBD or some kind of a biliary drainage should be done before going ahead with, let's say, an extended right hepatectomy. Try to minimize blood loss. That's a very important tool which, as surgeons, we have. Befriend your anesthesiologist. Convince him or her to reduce the CVP when we are operating. It will reduce the blood loss and it will reduce many more problems because of the liver resection. Save as much liver as is technically and oncologically possible. So whenever possible, do a segmental resection. Do not do a fancy major resection in a gallbladder cancer. It doesn't matter. If the liver resection is not much, the liver resection for gallbladder cancer is only meant for the margins. Another method of saving a little more of liver is what I often do, and which I call a little bit of cheating on the liver. That is, if I have to do, let's say, extended right hepatectomy for a hilar cholangiocarcinomas. Now just imagine the disease is in the hilum of the liver. It is not on the venous side, not on the IVC side. So once you have started doing a parenchymal transection as you would do for a right extended hepatectomy, when we go up, I generally turn a little more on the right side. I do not take the middle hepatic vein at its origin. Never I have taken middle hepatic vein at its origin because it is really dangerous. Very often middle hepatic vein and left hepatic vein form a common channel before entering the IVC. It is a very common thing. If we try to do that, then we end up injuring the left hepatic vein also. So middle hepatic vein is taken as it comes in the parenchyma. I go further right and take the right hepatic vein in the end. So a little bit of cheating on the segment 4A and segment 8 is done. This, we know that it is kind of devascularized, or it is hypovascular, that part which is left behind. It may lead to a little increase in serum lactates, little transaminitis, but this provides the hepatocyte for its hepatocytic function and prevents the post-hepatectomy liver failure to some extent. So these are the methods for saving as much liver as possible, technically or oncologically. Finally, preventing sepsis. because sepsis is an important factor which leads to post-hepatectomy liver failure. Again, post-hepatectomy liver failure leads to sepsis. So this is a cause and effect phenomenon for both these things. So these are the measures to reduce the post-hepatectomy liver failure. And I think that's all for me. And thank you very much. If you have questions, you're welcome to ask them. I'll try to answer. Thank you.
Thank you, sir. Thank you so much. Dr. Vivek, I think there are some questions with you. You can take them up.
I think we must thank Dr. Durgatosh, who like almost always that I've heard him very, very clear, very lucid, and a very, very good talk. So basically, few questions on the chat box. The first question actually was, any role of embolization? We would have to increase the size of FLR. We would actually go to options by which we can increase FLR, Dr. Durgatosh. The ways by which we can increase the future liver remnant.
So the future liver remnant can be increased by, the most common thing is portal vein embolization. So portal vein embolization, when it is done, if suppose we have to do a right extended hepatectomy for a hilar cholangiocarcinoma, as a first step, do a portal vein embolization on the right side. This will lead to the hypertrophy of the left lobe of the liver and atrophy, a corresponding atrophy of the right lobe of the liver. The liver resection may become a little more challenging because of this hypertrophy atrophy thing. It rotates, the planes rotate, but this can lead to increase in FLR. Even TACE is to me a very important thing, although it does not really increase the FLR, but it sometimes shrinks the side of the liver, the tumor, sufficient enough for limiting the side of the liver to be resected. For example, if it is in the segment 5 and 8, the HCC is in the segment 5 and 8. If we are doing without a TACE and a large tumor, we may need to take the middle hepatic vein along with it. But if we do a TACE, then occasionally the tumor gets off the middle hepatic vein and that can be spared. Now, once that is done, even sparing the middle hepatic vein gives a good venous drainage, reduces the chances of the post-hepatectomy liver failure, even if the FLR is not increased. So these are, to me, the major ways how the FLR can be increased.
Dr. Durgatosh, any few words about ALPS? You want to add something about that?
So ALPS is a procedure which has come in fashion now. We do not do it very often, but it is a procedure in 2 steps. This is another way to prevent a post-hepatectomy liver failure, in which the parenchymal transaction is done. And correct me if I'm wrong, Vivek. The parenchymal transaction is done in the first step, and the vessels are ligated and removed. The specimen is removed in the next step, which is maybe 48 hours later. This is how the ALPS. Yes.
Yeah. So basically, what we are trying to do in an ALPS, which is actually an acronym for Associated Ligation of Portal Vein with Liver Parenchymal Transaction for a stage hepatectomy. And essentially, what we are trying to do is, as Dr. Durgatosh talked about portal vein embolization, but actually is being done when you are doing a ALPS, for example, for a right or an extended right hepatectomy. Generally, for a left hepatectomy, you would not need, because unless it's a very, very kind of a partially atrophied right lobe for some reason, where you would actually be thinking about whether you should do a hepatectomy or not. The most common situation would be when you would be doing a extended right or a right hepatectomy. So you would ligate the portal vein as well as doing the parenchymal splitting. The rationale being that you take off all the portal venous blood supply of the non-feature remnant or the tumor side of the liver, and essentially the crossover branches from the other lobe as well as the right portal vein having been ligated. So that is basically the principle. You would actually do it more for primary parenchymal tumors, for biliary obstruction, patients with biliary obstruction, hilar cholangio and CAGBs. The risk of bile leak from obstructed bile duct and handling of the P2BDs causes a lot of biliary leaks and infectious complications, which where it is now being called a lot into question. And I think the perspective is that there would be some patients with colorectal liver metastasis sometimes, where you intraoperatively found the disease is a little more than what you thought. Intraoperatively ultrasound has picked up some lesions, or sometimes you're doing an HCC and you found another lesion which was picked up, not picked up on the initial imaging. So I think that completes the first question. The second question, which actually Shubham has asked, and actually it's a bouncer for me, so I'm going to put it directly to Dr. Durgatosh, is that when segment 4A and 4B have separate bile ducts and a separate portal and hepatic artery inflow, why are they labeled segment 4A and 4B? And why weren't initially the segments of the liver labeled 9 instead of 8? I think it's a bouncer. Dr. Durgatosh, you want to say something?
The only thing which I can say is that, see, the left medial sector is actually supplied by the portal tract, which actually comes back. So it is a recurrent vessels which supply it. So because of the recurring pattern of the vessels which supply the segments 4A and 4B, they must have been clubbed together. But I really do not know the answer to that question.
I think the only thing that came to my mind was probably by the time it was discovered that segment 4A and 4B were actually had separate blood supply, they had already been, the rest of the segments had been labeled probably. I am not really sure about that. And the third question which was there on the chat box is that, I think you'll just complete this question, Dr. Durgatosh. You talked about recurrent branches of segment 4 as well as segment 2 and 3 as well. So would there be, say, essentially the parenchymal transaction in an extended right hepatectomy versus a parenchymal transaction for a left lateral segment? Would you like to talk about the anatomic basis for why we do certain things in a certain way in an extended right hepatectomy versus when we're doing for a left lateral segmentectomy? Does it have anything to do with the vascular supply of the left lateral segment or the segment 4?
So as I said, the segment 4, the blood supply to the segment 4 recurs. Actually, the portal vein goes towards the left lateral segment and then branches from there. It will recur, which means it will come back into the segment 4. So if we have to do a safe resection, safe right trisectionectomy, then we should remain on the right of the falciform and the umbilical ligament, so that we divide those recurring branches rather than on the left side, where we can really divide the left side, the left branch of the portal vein, which is going towards the segment 2 and the 3. And for the other thing, when we are doing a 2-3 resection, the plane should be left of the falciform ligament and the umbilical ligament. So that's the
So essentially, what it means is that few branches, the portal vein as well as the hepatic arterial branches, they cross over back from the left to the right side into the segment 4 of the liver. And that is why probably what Dr. Durgatosh says has a lot of value. When we are doing an extended right hepatectomy, we have to preserve the blood supply of segment 2 and 3. And when we are doing a left lateral segmentectomy, we have to preserve the blood supply of segment 4. And that is why when we are doing an extended right hepatectomy, we stay on the right of the falciform ligament in the parenchymal transection. And when we are doing a left lateral segmentectomy for a tumor, you try to stay on the left side of the falciform ligament. Another question on the chat box, Dr. Durgatosh, is that when would you consider non-anatomic resection? So what would be the indications for a non-anatomic resection? And what would be the acceptable margin? And to that, I would add, would it depend on what kind of tumor are you treating about the acceptable margin for a non-anatomic resection?
It really depends on the kind of tumor we have. See, non-anatomical liver resection is always done by me for gallbladder cancers. If the liver invasion of the gallbladder cancer is not much, then the purpose of the liver resection in gallbladder cancer is only to get margins. So we do not do a fancy segment 4B and 5 resection always, although some people feel that leads to lesser blood loss, but it really doesn't matter. A much smaller amount of veg can be removed. So that is one. Second is in metastectomies. So for metastectomies, we really do not need to do an anatomical liver resection unless the metastasis is big, and the liver resection can be really challenging, where we should be doing a anatomical liver resection. For smaller metastasis, non-anatomical liver resection should be enough. For hepatocellular carcinomas, occasionally we do non-anatomical resections, especially for hanging tumors. If the tumor is hanging, then there is no real value in taking the entire lobe along with the tumor. So for hanging tumors, or a tumor which has a large proportion of the tumor which is hanging, or in cirrhotic tumors where we have to save a lot of liver parenchyma, so we do a combination of anatomical as well as non-anatomical resections. So in these situations, we do a non-anatomical resection.
So essentially, the aim of doing a non-anatomic resection is that you try to preserve as much of parenchymal, liver parenchyma as possible. And as Dr. Durgatosh has said, it would be applicable to patients in whom the liver functions is compromised or the liver is compromised for some reason. For example, there could be a patient, when we talk about metastasis for colorectal cancer, the patient could be having chemotherapy associated steatohepatitis. In a patient with HCC, there could be a compromised liver. There could be some fibrosis in the liver, even if not established cirrhosis. So that is where the role of non-anatomic resection would come in. And as Dr. Durgatosh said, segment 4B5 anatomic resection versus a wedge resection of the liver in a patient with CA gallbladder generally has never actually been shown to be showing any particular advantage in favor of an anatomic resection, except that probably the reported bile leaks are a bit lesser, but that's also very difficult to explain. So, Dr. Durgatosh, would you like to talk about the margin, liver metastasectomy and a colorectal and a primary HCC?
Again, I mean, there is no real study which has said that this much margin should be taken, although we tend to aim at 1 centimeter margin at least, but very often we fail to achieve that margin. If we are doing a metastectomy for multiple metastases, then sometimes you would all understand that sometimes it amounts to just pouring out some of these tumors, because you can take a good deal of margin on the periphery, but as you go deeper, if the vessel is just lying on it, then there is no point in taking 1 kilometer of margin on the periphery of the liver and taking less than a millimeter margin on the vascular side. So the margin, it should be a negative margin, and that should be it. We should aim at negative margin. Well, for hepatocellular carcinomas, when we are doing an anatomical resection, we should aim at that anatomical resection will automatically give you good margins. But for multiple metastectomies, aim at 1 centimeter margin, but finally we should achieve a negative margin.
I think taking up from there, it has been now.
For gallbladder cancer, 2 centimeter margins we aim, but again, it is the negative margin which is important.
I think over a period of time, what has been found out is that when you're dealing with multiple HCCs and you're trying to do some non-anatomic and some anatomic resections or combinations thereof, even a 0.5 centimeter margin on a HCC is considered adequate. When it comes down to multiple colorectal liver metastasis, parenchymal preservation becomes a little more of an important thing, because generally in a patient who's got significantly compromised liver function and liver cirrhosis and HCC, which is the most common setting, there you really wouldn't take up a patient for resection unless the patient is generally good. So for colorectal liver metastasis, sometimes the liver can be really bad. At surgery, it could be a lot of chemo associated steatohepatitis, and that is where the described margin is about 0.2 centimeters, and that is where what Dr. Durgatosh said has a lot of value, that deep down you can't take a margin, you start with a big wedge outside. So that is where the role of cylindrical resections, what people are talking about for colorectal liver metastasis, where it actually comes out as cylinder. So the margin kind of remains the same everywhere around the lesion, and you really do not go too wide when you start off with the dissection. Another question on the chat box is, any role of lymph node dissection in HCCs, Dr. Durgatosh?
So the standard answer to this question is there is no real evidence to suggest that lymph node, a systematic lymphadenectomy contributes to a better outcome in hepatocellular carcinomas. In cholangiocarcinomas, yes. In hilar cholangiocarcinomas, we tend to do a portal lymphadenectomy, but in HCCs, we generally do not do a lymphadenectomy, a systematic lymphadenectomy. When we are dissecting on the porta side, on the inflow side, but while doing that dissection, some amount of lymph nodes are removed, but a systematic lymph node dissection is not required for hepatocellular carcinomas.
Thank you, Dr. Durgatosh. Shubham, do we have more time?
We are not short in time, we are well in time, so that's not a problem. Dr. Rudra wants to speak something. Dr. Rudra, you can unmute yourself. I made you a co-host now, Dr. Rudra.
So he could ask his question, and then I could take up two other small issues.
Sure. Yeah, Dr. Rudra.
I think Durgatosh, that was very extensive and very nicely explained, especially for the students. But I have two questions. One is, as you told that biliary peritonitis and sepsis is one of the fatal complications of a major liver resection, then what are the steps to prevent it? Number one. Number two, regarding the margins, I think use of ultrasound during at least metastatectomy is a very great help intraoperatively to reduce to preserve the more liver parenchyma?
Dr. Durgatosh.
Yeah, I could not hear it very properly, but
I
I
think-
agree with Rudra that use of ultrasound is an important tool for metastectomies. We actually published it in 2006 that intraoperative ultrasound picks up 20% of the cases, or 22% it was, it picks up more metastasis than it was being picked up by a CT scan that time for colorectal liver metastasis. So it is an important tool for picking up metastasis. But I'm not very sure about the practicality of using intraoperative ultrasound to guide the margins, because it is theoretically very appealing, but often we are not able to do a circumferential clearing of the hepatic parenchyma around the each and every colorectal metastasis with the help of an ultrasound. Although what you say theoretically makes sense. The first question I did not hear properly. So what was it?
First
Vivek?
question was, how do you
Bile
prevent
leaks.
biliary
Bile leaks.
peritonitis?
How to prevent bile leaks, basically.
Bile leak.
How to prevent bile leaks, essentially.
Hello?
How to prevent bile
Yeah?
leaks. How to prevent bile leaks.
Bile. Okay. So bile leak, if you are doing more anatomical resections, there will be lesser amount of bile leak. That is one. Second, if we are using energy devices quite aggressively while transecting the parenchyma, the incidence of bile leak is more. If we are using, let's say, cheliclysis or a CUSA, we tend to see those bile ducts and clip them or ligate them. But while doing aggressively, if we are doing by, let's say, harmonic or a ligashore, then often those small little biliary radicals they are not seen when they are resected, and that leads to a bile leak. So the limited use of, or maybe more rational use of energy devices intraparenchymally and more amount of anatomical resections can prevent bile leak, postoperative bile leak.
Dr. Durgatosh, if I may add, basically most of my liver surgery training was as part of liver transplant teams, and that is where we know that people are very, very worried about biliary complications, especially in the donor. And from there, what I have picked up is the fact that two things help. One is standard use of CUSA, wherein you are sure you're getting all bile ducts very, very clearly, and you're not crushing any bile ducts and suturing and tying them well. That is one. And second thing is, I think patients, while dealing with the pedicles that you use CUSA or you use cheliclysis, whatever, you tackle the portal triad radicals very well. Like the bile duct artery and the portal vein would usually be going together, and there you are very, very careful about doing it. Second thing is, but routinely, which now I use in my practice, is also what I have learned from donor hepatectomy, is that we always cannulate the cystic duct as a part of the procedure in almost all patients, except obviously hilar cholangio, where it is not practically feasible. There we generally have a PTBD from where we can flush and see. So cannulating the cystic duct, flushing it with saline will pick up some leaks. Instilling some methylene blue will also show up some leaks. So you can actually suture them with a 6-OPDS, and that helps reduce bile leaks. And essentially, these are lessons which have been learned from the experience with donor hepatectomy, and it really does help reduce the bile leak rate. But then, because that's what the world over donor hepatectomy are generally the ones which are the most kind of precious ones, and that's where people do it this way.
Another thing, if we can spend 3 or 4 minutes at the end of liver resection, just inspecting the cut surface of the liver, even that helps.
Yeah, true. Agreed.
There. So we should not be impatient that the liver resection is over. Now let's close. Go to drain and close. Just inspect the cut surface of the liver for 3 or 4 minutes. We will see a little bit of bile trickling down from somewhere. Take a PDS 4O and suture it. So that can also reduce some amount of bile leak. Yeah.
So does the sealants help? Any sealants?
I have not used.
Kind of.
It is like a nightmare that you think confident that you have used sealants and it will stop. and suddenly you see gusts of bile coming next day.
I think
So
I
they
think
have
as,
never helped
yeah,
actually.
yeah, and I think one important area, Dr. Durgatosh, you would also agree, is the area of the caudate. And sometimes, especially when we are doing resections for a hilar cholangio, we are excising caudate as a part or not excising caudate as a part of a right or a left hepatectomy. It is extremely important to look at the surface of the caudate lobe, and that is where you would get very very tiny bile ducts, which would, because caudate has biliary drainage both into the right and the left duct, and so sometimes you'll have done a right hepatectomy and a part of caudate has been taken, and part of the caudate bile duct has been kind of divided. So that's an extremely important area to look at. And these leaks can sometimes be very, very stubborn and take quite some time to. Otherwise, if it's a minor duct leak or a small parenchymal leak, it will generally settle down with a adequate drainage.
It stops by itself generally.
Yeah,
So
it will stop by itself.
So when we do a caudate lobectomy along with a right hepatectomy, right extended hepatectomy or left extended hepatectomy, in that case, the part of the caudate from where it has been resected, what I generally do, we know that there will be small little bile duct channels which will be open. So you take a suture and take, even if it is not seen, take blindly a few sutures to just compress that part of the caudate lobe which has been cut, which is remaining with the patient. So if we do that, that probably, I do not know, but that probably would reduce.
And actually, what I've learned from the donor experience has also been that, say for example, you've done a right hepatectomy, so there would be a kind of a thickened capsule, fibrous Glisonian sheath, or a condensation of that around the caudate duct, or the area into which the caudate duct would be joining into the right duct. So there you see it as an extension from the left or the right duct, and you actually suture the tissue cranial and to the left in a right hepatectomy, and cranial and to the right of a left duct or the right duct as applicable. And that also helps reduce the bile leaks. That's what most donor surgeons would do as well. And so that's the lesson we've picked up from there. Dr. Durgatosh, I have one more question. One thing which you could probably add up and complete it, because I have put the question number 5 in the quiz for that, is whether you would differentiate extended right hepatectomy for, say, a liver tumor versus for a hilar cholangiocarcinoma. So I have to ask you that question so that people can get the answer for question number 5 in the quiz.
Yeah, please tell me again the question.
So when we are trying to do an extended right hepatectomy for, say, something which is a liver tumor, primary parenchymal liver tumor, versus when we are doing an extended right hepatectomy for a hilar cholangio. So what would be the kind of surgical things which would be a little different in the two situations?
Okay. So basically the main difference is the inclusion of caudate lobe as a part of resection. So if we are doing a liver resection for a hilar cholangiocarcinomas, then we would probably include it is better to include the caudate lobe as a part of resection along with the right extended hepatectomy, which means that it will be segment 4A, 4B, 5, 6, 7, 8, as well as 1. So that will be the classical right trisectionectomy plus a caudate lobe resection for a hilar cholangiocarcinomas. Why do we do that? It is because the tumor which is at the hilum, we know that there are tiny branches from the bile duct from both the right side and the left side, which go into the caudate lobe. If we do not resect that, then we don't get that margin on the caudate lobe, and that is where the tumor might recur. So a caudate resection becomes an essential component for a hilar cholangiocarcinoma surgeries. In a primary liver tumor HCC, it is not so. So we just do a right extended hepatectomy and leave the caudate behind.
Yeah, and essentially another important difference would be that in a hilar cholangiosis, the disease involves the bile duct, we would do a bile duct excision as well.
Extrahepatic bile duct resection is an essential component for this kind of hilar cholangiocarcinomas. For liver tumors, it is not required.
It is obvious.
I was talking of only the liver part.
Yeah. So basically, I wanted to complete that answer to that question here, Dr. Durgatosh. Okay. So over to you, Shubham.
Yeah. Thank you, sir. Thank you so much. That was a very interesting discussion, and I had a chance to hear Dr. Durgatosh first in 2009 in the Surgicon. The MAMC Surgicon that is organized every year by Dr. Sarda, and I was equally mesmerized with the liver anatomy that Sir showed us that day. And today's talk actually brings back all those memories. And he was standing there in the MAMC auditorium, and we thought, when will we do a liver resection as a first-year PG in surgery at that time? So thank you, sir. Thank you so much for that lecture. But right now we'll move on to the quiz, and I would want Dr. Mangla to tell us the answers to the quiz. I'm sure all of them have mostly been covered with Sir's talk. But also I would want Dr. Geeta to come in to tell us how many people participated and who got what right. But let me start with Dr. Mangla first. So Dr. Mangla, these are the answers, and just tell them, explain the answers as we go along.
Yeah, this question essentially, the fourth statement, as Dr. Durgatosh rightly said, the middle and the left hepatic veins usually unite together before joining the ICC. The significance of this has already been told. Just to reiterate, you don't try to take the middle and the left hepatic veins separately unless it's absolutely essential. You try to take them within the parenchyma and stay a little towards the liver side. The RHV is usually larger than the LHV or MHV. This is an extremely important fact because the right hepatic vein drains the largest part of the liver. The caudate veins drain directly into the IVC, and these are the small tributaries which Dr. Durgatosh was talking about when they can bleed when you're trying to blindly do a hanging maneuver. And the important part of intrahepatic venous tributaries, the hepatic venous tributaries, they're not surrounded by fibrous sheaths just like the portal triads. The portal triads have their Gleasonian sheath which goes with them. And these are covered by capsules. So when we are trying to use a CUSA or even for that matter a cheliclysis, the vein and the portal triad behaves very, very differently to both the CUSA as well as the cheliclysis. And the hepatic veins tend to be friable. So one has to be very, very careful when we are trying to do cheliclysis, and the small veins obviously have to be tight, just like the portal triads. The important thing is that the veins are actually not surrounded by any fibrous tissue. And though you try to take a little bit of a parenchyma over them or just try to bear them out and then try to tie them. Shubham, the next question. So this was another very basic question which Dr. Durgatosh also talked about. The Cantonese plane divides the right and the left hepatic, the right and the left liver, and they are in this is also called the principal plane into which the middle hepatic vein, the right anterior and posterior segments of the liver are actually separated by the right hepatic vein and not the right inferior hepatic vein. Right inferior hepatic veins usually drain segment 6. The right and left liver are not separated by the falciform ligament. It's actually the right and left lobe of the liver as was described conventionally, which are separated by the falciform ligament. And the left liver is obviously divided into, sorry, this question actually, the fourth statement is also correct, Shubham. The left liver is actually divided to segment 4 and segment 2 and 3 by the left hepatic vein as well. So these actually 1 and 4 both are correct. So you just have to, sorry for this oversight from my part. We can go to the next question. So we are at a level above the division of the portal vein bifurcation, and above this level, this part of the liver would generally be segment 2, and at a level below this, below the level of the bifurcation, this would be segment 3 and this would be segment 2. Sorry, the answer is segment 2, Shubham.
Okay.
Yeah. So we could go to the next. So as Dr. Durgatosh has already showed the right and left hepatectomy, so obviously this is a non-anatomic specimen. At best, you can call it a monosegmented, but it's actually a non-anatomic resection for an HCC. And this picture essentially shows a hilar cholangiocarcinoma. Shubham, you could just drag the mouse. Yeah, it shows a hilar cholangiocarcinoma involving the left cup. And there is atrophy of the left lateral segment. There is a lot of hypertrophy of the right posterior sector. Here in the picture, the right posterior sector is mentioned. And here you can very clearly see the caudate lobe, which has also been excised. And we have already discussed this. So a standard resection for a hilar cholangio 3A extending to the left side would be an extended left hepatectomy with a caudate resection with a CVD excision. And hence 2 is the right answer.
Okay. So this was the key actually. So now the question 3, the answer is 2 and not 1. So the correct is 41242, Dr. Geeta. So 41242.
Yeah, I apologize, Shubham and
Yeah.
Dr. Geeta, for this.
That's
No problem.
So we Dr. Geeta will yeah, Dr.
Okay,
Geeta.
so there were 3 participants only. I think the reason was probably for the last couple of meetings we did not have a quiz, so probably people thought we were not going to have one, but we did. So there were 3 of them, but there was one who got 4 out of 5 right. Not any of them. Not any of the 3 got all 5 right. So Prudvi from TMH got it right. So she got 4 out of the 5 questions right,
So
including the one that Vivek just corrected.
Yeah, sorry, ma'am. I apologize.
So which one was the one which was not right? The 5th one?
The 3rd one, I think it was the 3rd question, which was marked as 1, but I believe it is 2.
Yes.
Yeah,
Is that right?
segment 2. Yeah.
Okay. Okay. Great. 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 So I think we have had a wonderful lecture, and thank you, Dr. Durgatosh sir, for sparing your time and giving this wonderful tutorial for us. Technology has helped us to reach out to a larger number of audience, and actually, we have it has enabled us to meet teachers like you, and it has become easy for us to request you to take tutorials like these for us. And with this, we also have these tutorials recorded. They are saved in our archive and are available on our YouTube channel, which is Cancer Academy. And I must say that the number of visitors which are there on previous lectures is very, very encouraging. I don't know why we didn't have classes like these before, and thanks to COVID that this technology we have discovered. Continuing with a series of wonderful speakers, the next week the speaker is going to be Dr. S.V. Deo, who's the professor and head of surgical oncology at IRCH Ames and NCI Jhajjar. And he will be speaking on chest wall resections. So just like Dr. Pandey, he is also a teacher par excellence, and he can speak on any topic given to him. But having worked with him, I am he is chest wall resection is something that is very close to him. He actually enjoys the reconstruction part a lot. So we will be looking forward to that lecture, and we will again be back with a quiz next time. So I'm sure we'll have more participants. So
And we're going to do a prize next time.
okay.
Just to encourage more
We'll,
participation, we'll do a prize next time.
we'll arrange a prize also. We'll arrange a prize.
Yeah.
Okay. Okay. So thank you so much, everybody. Thank you, Dr. Pandey. Thank you, Dr. Mangla. We had a very good audience today. I mean, there was Dr. Mahesh Goel there in between. There was Dr. Chandramohan there. There was Dr. Shraddha Patkar, Dr. Naveen Sancheti, Dr. Pankaj Garg from AIMS Rishikesh. So we had really good surgical crowd. And for a niche topic like liver resection, I would not expect a lot of non-surgical people to be around. But having a great discussion moderated by Dr. Bangla was the icing on the top. So thank you, everybody, and good night, and see you next Wednesday. Thank you.
Thank you. Thank you, Durga. Thank you, Vivek, for a wonderful session.
Thanks, ma'am. Thanks, Shubham. Good night.
Bye-bye. Good night.